revealed was psychiatric symptoms were almost present in a third of the patients, and commonest symptoms were depression and anxiety. Now, looking at the symptoms, we have these two broad categories. On the left of your slide, left-hand side, you see motor symptoms. On the right side, you see non-motor symptoms. The non-motor symptoms can themselves have a wide variety of manifestations. Like Thomas had mentioned, hyposmia can be initially present very early on. Along with that, GI symptoms can be present. Other than these, other symptoms can start adding up, which can involve neuromuscular symptoms as well on the motor side, as well as cognitive symptoms and depressive anxiety symptoms among the psychological symptoms. So when we look at these, this list has come from Aging Reviews, one article which I was able to find, a recent article. And now this classifies the non-motor symptoms as neuropsychiatric, cognitive, autonomic, sleep, sensory, motor. And it also lists these symptoms which are possibly premotor or appearing in the very early phase of Parkinson's disease. So what it has listed here as premotor are anosmia, constipation, REM sleep behavior disorder, and depression. So among the psychiatric symptoms, it lists quite a few. We will also look at one more article by Kamar et al. Has again looked at them as neuropsychiatric as one category, then autonomic, sleep, and sensory. So it has looked at as 4 broad categories of non-motor symptoms. Now, moving on. So these are the neuropsychiatric conditions which we will try to cover in the current presentation. Parkinson's disease, depression, anxiety that is found in Parkinson's disease, apathy, impulse control disorders, psychosis, cognitive impairment, and fatigue. So before moving on to them, from this article from Kalia and Lang from Lancet 2015, what you can see is this gives a nice timeline of how the illness can evolve. Probably at 0 is what motor manifestations start coming up, or early motor manifestations, and we are able to diagnose them as possible having early phase of Parkinson's. So here what we see is the prodrome phase, where you can see constipation, sleep related issues, anxiety, depression can be part of the prodrome itself, and hyposmia, apathy, executive dysfunction, these also. You can also see hallucinations can also start occurring earlier on, and these can be in the form of what are called as minor hallucinations, often clarified in different Parkinson's context as illusions which can occur, which can be visual. So these perceptual disturbances again can be something which are slightly unusual and found often in Parkinson's disease. Then again, the motor symptoms start manifesting associated with other add-on non-motor symptoms like fatigue, pain, and then add-on further worsening. And almost all throughout the illness, there are psychiatric conditions. And as the disease advances, more problematic conditions like full-fledged psychosis and cognitive impairment can add and worsen the overall prognosis as time passes. Need for hospitalization can also go up. Right. So the one difficulty which comes with assessment of Parkinson's disease, this is again from Aging Reviews, this figure that I could get, is one difficulty is overlap of clinical symptoms between a psychiatric condition and Parkinson's disease. So for example, if we take in this figure what is illustrated, overlap between symptoms of depression and Parkinson's disease. There are overlapping somatic symptoms which can be in the form of fatigue, insomnia, loss of appetite, decreased energy, weight changes, erratic sleep patterns, indecisiveness, muscle tension, sexual dysfunction, and gastrointestinal problems. So moving on from here, from the description of symptoms to the estimates of depression and other psychiatric disorders. When we look at the estimates of depression in Parkinson's disease, they vary widely among studies, reported from as much as low as 7% to as high as 76%. And the difficulty is also because the varying definitions that have been used and how one has screened for depression and overlapping symptoms and what approach is used for these overlapping symptoms. So an inclusive approach is often resorted to by quite a few researchers. So there are different advantages and disadvantages of having such an approach. So an inclusive approach may end up overdiagnosing the number of patients with depression. And it is important to identify depression because most studies do find that depression is an important determinant of quality of life in Parkinson's disease. And depression is also related to other problems like cognitive decline, falls, worsening symptoms, and increased caregiver distress. Now, anxiety can be often noticed when we look at the prevalence of anxiety. We can often notice it at the disease onset. And during the course of illness, cumulative prevalence can be as high as 40 to 50%. And we have to also understand that comorbidity of psychiatric symptoms is very high as the disease progresses. So depression is often comorbid with anxiety, and anxiety may present as unspecified anxiety many a times, or it may take forms of clear diagnosable anxiety like generalized anxiety disorder, or it may become situational like social phobia, or it may take the form of a panic disorder. Both depression and anxiety can occur in a third of patients as part of the off periods as the treatment with dopamine agonist therapy goes on. So patients who are on 4 to 5 years or longer on levodopa therapy may start experiencing depression and anxiety symptoms as well as slowing during off periods of medication. That is, whenever the levodopa effect starts waning after 2 to 3 hours, they may start having difficulties. Psychosis, again, cumulative prevalence can be as high as 60% among patients with Parkinson's disease, and the chances of having psychosis increase with advancing age, and high risk of hospitalization and long-term care occur as full-formed psychotic symptoms start appearing. In the initial part of the disease, there can be presence of minor peripheral visual hallucinations, which can be as if somebody is passing by, but they're not able to clearly identify who's passing by, which are called as passage phenomena. Or a patient may report that there is somebody present around them, although they are not able to tell who or what it is. And this might also at times worry them initially on. And these can be at times fleeting and may pass away, or at times persist for a longer duration. As the disease progresses, patient may often report commonly visual hallucinations. These visual hallucinations can start initially with poorly formed to move on to complex visual hallucinations. And again, the patients can have a fluctuating or varying insight into these phenomena as well. So they're far more common than other forms of hallucinations, although there are a few studies which have also reported that auditory, tactile, and olfactory hallucinations are also often reported by patients. Comparatively, delusions are fewer, around 2 to 3% of psychotic phenomena are delusional in nature as per some studies. Some studies report as high as 5 to 6% of the 5 to 6% of the psychotic phenomena are delusional in nature. Another important concern in patients with Parkinson's is apathy, which is described as diminished motivation, which cannot be attributed to decreased level of consciousness, cognitive impairment, or emotional distress. Now, again, apathy, when you are diagnosing, you'll need to carefully elicit history and also look out for presence of depression or any other factor, any other psychological factor that has been causing inhibition. Is it some kind of an anxiety which is causing avoidance and lack of interaction? And prevalence can be as high as 35%. And apathy often overlaps with depression and cognitive impairment, and is a poor prognostic factor and very difficult to treat because of the varied natures, hypothetically varied natures by which apathy can arise in Parkinson's disease. An interesting category of psychiatric conditions among disorders, although they are comparable with general population for in terms of prevalence, they are comparable for newly diagnosed untreated PD patients. But prevalence in Parkinson's patients receiving treatment goes high, and it reaches as high as 15%. And also the phenomenology varies by gender. We'll come to that later on. And cumulative 5-year incidence in one study has been reported as high as 46%. Now, coming on to correlates and risk factors for these neuropsychiatric symptoms and conditions. In cross-sectional studies as well as in longitudinal studies, we have looked at different correlates as well as risk factors. And understanding these can facilitate targeted screening of individuals who are possibly in an early stage or who are at higher risk, possibly have some family history of a neurological or Parkinson's disease. And again, the difficulty in assessing these becomes very evident because of the frequency with which they are reported and large individual variations, as well as variations within different geographical areas, time of onset, variable time of onset of many of these neuropsychiatric conditions, as well as severity of these, which can vary between patient to patient as well. And are they specific? It is very difficult to say that these risk factors or correlates are very specific to the neuropsychiatric condition. When we look at old age as a risk factor for Parkinson's disease, psychosis, cognitive impairment or psychosis, we are also looking at cognitive impairment occurring in general population as well with aging. Similarly, cognitive impairment in a lower educational level is also very clearly associated also with people in the general population who don't have Parkinson's disease. So possibly there might be some bidirectional risk associations, which we are not very clearly able to delineate at this point of time. So looking at the correlates and risk factor for depression and anxiety, female sex, younger age and past history of depression or anxiety are associated with and are correlated with the presence of depression and anxiety. And the factors which have been bolded in bold are associated with both depression and anxiety, whereas the factors which are not in bold are just associated with depression. So family history of depression is again a risk factor for development of depression among patients with Parkinson's disease. Likewise, cognitive impairment also predisposes them to a development of anxiety. REM sleep behavior disorders are associated with depression. These have been found in different kinds of systematic reviews to be associated. And other non-motor features like constipation, fatigue are associated with depression. Pain is associated with both depression and anxiety. And disease duration is again correlated with presence of depression. On-off phenomena, again, presence of depression. Other factors which can possibly be protective, having a spiritual well-being as well as a good social environment, access to multidisciplinary medical services and sustained employment. These are possible protective factors. And a risk again, risk can be increased because of psychological factors which can involve negative thoughts about the diagnosis, future progression, and perceived social consequences of Parkinson's disease, as well as lack of self-perceived control over the ability to cope with Parkinson's disease. Among impulse control disorders, the risk factors include dopamine agonist therapy, a young age at onset. Sexual differences exist in terms of how they manifest. Males often manifest with some kind of sexual impulse control disorders. Women will often manifest with shopping or some kind of a grooming activity which can be present. And family or personal history of substance use disorders can be a risk factor. Again, some studies have looked at D3 affinity of compounds which are used predisposing individuals to impulse control disorders. There is only one study which has looked at, tried to delineate whether impulse control disorders are associated with any other neuropsychiatric condition independent of dopamine agonist therapy. That study does propose that anxiety is independently associated with impulse control disorders. They were able to say that by looking at a group of Parkinson's disease patients who were scan negative for dopamine dependency. So saying that these patients did not have a dopamine transporter deficiency. So these patients probably they were able to analyze and say anxiety in them was independently correlated with the presence of impulse control disorders. So negative affect states probably independently influence occurrence of impulse control disorders. Again, apathy, when we are looking at male sex, older age, lower education, these have been associated with development of apathy. Cognitive impairment is again. So what you're seeing is presence of these conditions can co-occur, and co-occurring can also worsen the overall management and the difficulty for the multidisciplinary team. Presence of depression can also increase the chance of apathy, increasing severity of PD. Again, whether apathy can occur after DBS, and what does it represent? Does it represent an effect of deep brain stimulation, or it represents an effect of withdrawing dopamine therapy during the phase of deep brain stimulation is something difficult to say, although few studies have said that it is an independent effect of DBS and probably not just ascribable to withdrawal of dopamine agonist therapy. Now, psychosis, the risk factors include cognitive impairment, aging, disease duration, REM behavioral disorder, REM sleep behavioral disorder, excessive daytime sleepiness, depression, dyskinesia. So presence of these again increases the chances of psychosis. And again, many of these risk factors are not very specific to Parkinson's disease psychosis. It is very difficult to say that they are very specific to Parkinson's disease psychosis. And dementia, chances of dementia are higher among those who are experiencing hallucinations, have an older age, lower education, depression, overall severity of motor symptoms, speech impairment, older age at onset of Parkinson's disease, higher staging on the Hone and Yar stage. So this Hone and Yar stage again tries to classify Parkinson's disease based on the motor impairment in terms of stage 1 being unilateral, stage 2 being bilateral, and again stage 3 has further problems in terms of postural imbalance, and stage 4 becomes quite severe, although patient can independently stand and walk, and stage 5 the patient becomes wheelchair bound and it is difficult for them to ambulate independently. And axial impairment, again, although this axial impairment is also part of Hone and Yar staging, so modified Hone and Yar staging does incorporate this. Now, moving on to the neurobiology of Parkinsonian symptoms, we cannot look at isolation at the non-motor, that is neuropsychiatric symptoms, but still what has been, this is taken from the original by Brack et al., which was modified in an article in Lancet. And Brack et al. Gave a staging system for Parkinson's disease, in which they reported that stage 1 involves the olfactory bulb, stage 2 starts involving the medulla, and then after that, stage 3, it starts progressing caudal rostrally and starts involving the, from medulla, it starts progressing to the pons and then goes on to the midbrain, stage 3, and following which it starts progressing to the cortical area, stage 4, 5, and 6. So after stage 4 limbic cortex, it will start progressing also mediolaterally and starts involving the memory areas as well as posterior parietal cortex. So they propose that this kind of progression is associated with different kinds of symptoms, which we also saw in a timeline, which was there in the article by Kalia and Lang. And also in this place, what you can see is certain genders like men and women, there are differences. So women are more prone for hallucinations, depression, insomnia. But again, depression, insomnia are common among women without Parkinson's disease as well, what has been reported in epidemiological studies. So it is difficult to right away commit. Now, men more often manifest with cognitive impairment, dementia, excessive daytime sleepiness, apathy, impulse control disorders. Now, among them also, again, it is very difficult to say, but possibly impulse control disorders have some association with treatment, dopamine agonist therapy, and there are phenomenology-wise certain different kinds of impulse control disorders like funding, hobbyism, which manifest, and they can be very difficult to explain. Just going with some kind of Parkinsonian pathology, or it is part of treatment related evolving pathology, is hard to explain. younger age predisposed to depression, older for hallucinations, cognitive impairment, dementia, and apathy. Baseline disease severity, higher severity is often associated with cognitive impairment, dementia, hallucinations, depression, apathy, excessive daytime sleepiness, and insomnia. Now, again, trying to look at these from different perspective, impulse control disorders, how they can arise, and dopamine dysregulation as well, which can occur as we start with agonist therapy. We'll come to these. So moving on to the neurobiology, possibly we are looking at a complex biological as well as psychosocial interaction with the biological vulnerability. So genetic basis has been looked at. Specifically, some monogenic variants progress differently. So there are at least 2 monogenic variants which have been reported to progress faster in terms of neuropsychiatric symptoms evolution and also increase severity of the neuropsychiatric symptoms. And again, when we look at what causes these changes in Parkinson's disease, one can hypothesize abnormal folding of the alpha-synuclein, which causes aggregation of these Lewy bodies, which is potentially neurodegenerative, which can cause degeneration of the neurons. And these changes can also be manifest secondary to a loss of dopaminergic neurons as well as non-dopaminergic neuron changes, which include neuron clusters in the brainstem, specifically noradrenergic, serotonergic, and cholinergic clusters of the neurons. Other proposed hypotheses have been a possible role of inflammation, how inflammation can contribute. Again, in inflammation, the alteration of expression of receptors like cannabinoid receptors, they have been looked at and are a potential research avenue. Gut-brain axis dysfunction, looking at the microbiome alteration within the gut, as well as small vessel disease itself contributing to the disease progression. These are different hypotheses which have been put forward from a biological perspective. Now, these all vulnerabilities can be individually or in a combined manner adding to the manifestation, and that in an individual will be interacting with their psychological makeup as well as their interaction with their family and others, and will be manifesting in different ways. So the disorders of affect can occur in prodromal phase when we look at their neurobiology, and they can again progress as the illness progresses and severity can go up. Whereas often it is seen that depression worsens over time as the disease progresses, but anxiety more or less remains in terms of prevalence, it remains static. But the severity of anxiety can go up. So again, the dysfunction of brainstem, monoamine and indolamine systems is proposed. And some genetic variations contribute to possible Parkinson's disease depression. These 3 have been identified: BDNF, TPHT2, and SLC6A15. And alpha-synuclein deposition in the substantia nigra, ventral tegmental area, and nucleus accumbens possibly also initially on start affecting many of the circuitries which are involved in the midbrain as well as the limbic system. Now, anxiety in Parkinson's disease, again studied around the fear circuit, involvement of amygdala, reports of atrophy of the amygdala and the anterior cingulate cortex. And other than these, there is an increased functional connectivity between the amygdala, orbitofrontal cortex, and hippocampus, and as well as increased connectivity between the striatum and the medial prefrontal cortex, temporal cortex, and insula. Also, they have demonstrated reduced functional connectivity on fMRI and EEG-based studies between the lateral prefrontal cortex and the orbitofrontal cortex, as well as hippocampus and amygdala. Other than these, anxiety has been proposed to be a manifestation of altered levels of neurotransmitters, a dopaminergic deficit, or a deficit in serotonin or norepinephrine system. So the anxiety, again, its responses also vary compared to anxiety seen in general population in terms of response to medication. Now, disorders of perception and thinking. Minor hallucinations can be present in untreated Parkinson's disease, which possibly indicates that they are not related to dopaminergic therapy and possibly a manifestation of the disease process. Visual hallucinations have been proposed to be, one is chronic dopaminergic therapy is possibly causing them. The other hypothesis have been cholinergic deficits, an imbalance of dopamine and serotonin. One more hypothesis which has been put is deafferentation, wherein the inputs to the association and visual cortex is impaired, which results in spontaneous activity within the association visual cortices. And other than these, attention and visual-perceptual alterations are other deficits which possibly are linked to visual hallucinations. Other than these, APO-E4 and GBA variants are linked with psychotic disorders, presence of psychosis. Neurodegeneration has been proposed as one more mechanism, which we already looked at in the previous disorders. The motivation disorders, there is one discussion which says that dopamine overdose hypothesis, wherein dopamine agonist therapy results in correcting of the dopamine deficit in dorsal striatum, whereas the ventral striatum, which is possibly not having deficits, is probably receiving a surplus of dopamine, resulting in different kinds of impulse control disorders. And it has been associated with also altered D2 and D3 dopaminergic receptor function, as well as altered striatal cingulate and orbitofrontal cortex activation. Some studies have looked at altered corticostriatal connectivity in fMRI studies and EEG studies. And some nucleotide polymorphisms can predict the occurrence of impulse control disorders. When we look at apathy, apathy again is linked with disruption of the networks between medial orbitofrontal cortex, anterior cingulate cortex, and ventral striatum. And dopamine as well as other neurotransmitters have been implicated. Although conclusively, it's not possible to just implicate one single neurotransmitter. Some studies have looked at altered connectivity between limbic circuits and the prefrontal cortex. Now, moving on further from neurobiology to screening for non-motor, specifically the psychiatric symptoms. So often in a setting where a patient with Parkinson's consults a general physician or a neurologist or a geriatric medicine specialist, these are scales which have been listed in one article from Lancet that I've looked at, which have been used. What it is trying to suggest is, one is the Movement Disorder Society has this UPDRS scale, which can screen, although many of these screen questions are single questions, single item questions, like apathy has just a single question. So it is difficult to right away conclusively diagnose. Possibly it would be better for if they screen positive for a psychiatric evaluation or further use of a specific scale in that condition. So what we look at is UPDRS has a screen for depression, anxiety, psychosis, apathy, and impulse control disorder. And then there are other questionnaires which have been used. The widely used neuropsychiatric inventory has not been specifically validated for Parkinson's disease, but it does have items for depression, anxiety, psychosis, apathy. And then there are other scales which are available. The non-motor symptom scale has a single domain for which assesses both depression and cognitive dysfunction. So these are the brief screening scales which are available. When we go specific to an individual disorder, say depression, we look at a wide variety of scales which have been used, which include Hamilton Depression Rating Scale, Montgomery-Åsberg Depression Rating Scale, as well as Zung Depression Rating Scale. The difficulty with most of these scales comes with the somatic items, the load of somatic items. Some studies have looked at abbreviating these scales and trying to look at if having fewer somatic items can effectively screen for depression. And other than these, the other scales for depression which are available are geriatric depression scale, which is fairly useful in context of Parkinson's disease. In the context of anxiety, established scales for anxiety like the Hamilton Anxiety Scale is not very useful. Also, hospital anxiety and depression scale is not very useful. What the Movement Disorder Society suggests is they have devised a scale called Parkinson Anxiety Scale, which is possibly an option. But then whether it has been fully validated in all cultures and across languages is difficult, but they have tried to devise this scale specifically for Parkinson's. So that is one. And in the context of apathy, again, there is a discussion on scales, which says that there are few scales like Lil's apathy rating scale. And other than Lil's apathy rating scale, there is a apathy scale, which has been suggested by Movement Disorder Society as a useful way of rating apathy. And rating any of these, depression, anxiety, apathy, is quite complicated because many of the non-motor symptoms overlap with the Parkinson's disease illness itself rather than with the neuropsychiatric condition. Now, moving on to treatment of depression. What has been evident at this point is there are systematic reviews and meta-analysis which seem to support use of SSRIs and SNRI. More preferable are SSRIs. And SNRI, among SSRIs, citalopram has been studied, as well as some other SSRIs have been studied. And SNRI, venlafaxine to some extent has been studied. And among tricyclics, nortriptyline has been studied, and there is possible role for them in the treatment of depression. We'll come to that again, right? So, and reversible MAO-B inhibitors as a monotherapy are not recommended. There are some trials going on with this newer reversible selective MAO-B inhibitor, safinamide, but still we are not there as of yet for use in Parkinson's disease depression. Non-pharmacological interventions are important, especially exercise and CBT. Exercise in different forms has been recommended by some articles, aerobic exercise as well as some forms of training exercises have been recommended. And exercise is a key important part of a Parkinson's disease therapy, because that is one way that one could work both on the motor and non-motor symptoms, especially the neuropsychiatric symptoms of Parkinson's disease. There is inadequate evidence for RTMS as of now. Trials are on way, but as of now, there is inadequate evidence. When we look at the pharmacotherapy of depression in Parkinson's disease, 3 meta-analyses have reported an improvement in depression symptoms with SSRI and also with behavioral interventions, including CBT. However, 2 meta-analyses have reported that antidepressants were not better than placebo. At this point, most often patients are treated with SSRI in many settings, and they are the first line preferred in the clinical context, given that the overwhelming evidence is probably in favor of them. There is no clear consensus on the treatment of anxiety in the context of Parkinson's disease. Visperon has one trial, randomized trial, and there they felt that the tolerability became an issue, and benefits probably were overwhelmed by the tolerability of Visperon. Again, SSRIs have been used in clinical practice and continue to be used. But again, conclusively demonstrating that they are effective has not occurred as of yet. Primarily also related to the fact that trials for both depression and anxiety in Parkinson's disease are fraught with: one is difficulty in diagnosing, second is not detecting it convincingly, as well as often patients going untreated. So patients are often missed out. Low-dose benzodiazepines have been used. One trial is there for bromazepam. CBT has been found to be effective, especially in terms of reducing avoidance, situational anxiety, and social anxiety. Other non-pharmacological approaches have been tried, which include mindfulness-based therapy, as well as some other forms of therapy like dance therapy has been proposed in a few trials. These have been looked at. Now, what is the evidence for treatment of psychosis in Parkinson's disease? Rivastigmine has a fair degree of utility, as well as donepezil, and the evidence is somewhere in case series to RCT levels. But more than them, in established psychosis, drugs which have been used are clozapine, and in trials, pimavanserin have been used, and both have RCT supporting them. Now, the drugs which are used but not having Established evidence are quetiapine, aripiprazole, risperidone, and ziprasidone. Quetiapine especially is used quite extensively. And many opinions and reviews state that clozapine has been underused, and probably it is one of the best agents to be used because of its effect also on improvement of motor performance. So, the dose needed for treating treating psychosis is possibly slightly lesser than what is needed for improving the motor performance in patients with Parkinson's disease, especially as the disease progresses and in the presence of psychosis, the motor control is also slightly poor. Now, other treatment which exists for several of these conditions, which has been tried for at least depression, is ECT. Electroconvulsive therapy is quite effective for both the depressive symptoms as well as the motor symptoms of Parkinson's disease. Likewise, ECT possibly is effective in psychosis, but again, evidence overall in psychosis is sparse because the number of patients who have been enrolled and systematically studied are poor. Treatment of apathy in Parkinson's disease, there are RCTs which have involved rivastigmine and pyribedyl, but not found them very effective. Ropinirole, pramipexole, and rotigotine have been tried in open-label trials. Again, not much of an evidence. SSRIs have been in trials demonstrated to worsen the apathy. Bupropion, there is one study which reports that there was improvement in apathy in Parkinson's disease. Overall, the evidence for treatment in apathy is quite sparse, and we are not able to get there in terms of what could be used. There are suggestions for use of methylphenidate, again, not very convincing. Again, a treatment of fatigue, another condition which is important and overlaps with other psychiatric conditions in Parkinson's disease, has been looked at, and nothing has been found conclusive. There have been trials which have looked at dopaminergic medications, methylphenidate. They may possibly improve fatigue, but it's not conclusive. Non-invasive brain stimulation, exercise, and deep brain stimulation may also help, but there is no conclusive evidence. Most of the trials in fatigue are underpowered, and it's often an overlapping construct and difficult to delineate. And there we do not have enough evidence. Now, treatment of cognitive impairment for dementia, established Parkinson's disease dementia, rivastigmine has established evidence in terms of efficacy. There is insufficient evidence for donepezil and galantamine, but donepezil is often used clinically and is possibly useful. Memantine, there is insufficient evidence in terms of efficacy. Side effect profile is probably acceptable. Other treatments for cognitive impairment which have been looked at are exercise, deep brain stimulation. Deep brain stimulation, looking at stimulation of nucleus basalis of Maynard, has demonstrated not much efficacy. But the trial was very small. They did find that among the 6, 2 or 3 patients had a response in terms of improvement of visual hallucinations, if I'm right. So that was one thing in stimulation with NBM. And one study which has looked at is a systematic review which has looked at DBS stimulation of subthalamic nucleus versus globus pallidus interna. This has reported that globus pallidus interna stimulation was probably better, and those patients over time showed fewer cognitive impairments, although we do not know how stimulating one versus the other is adding to the cognitive deficits. There are negative studies for rivastigmine and rasagiline for mild cognitive impairment in the context of Parkinson's disease. Now, coming to RBD, REM, sleep behavior disorder, RBD, in the context of Parkinson's disease, this diagnosis is largely based on history or visualization with polysomnography, where you would want to record the video event as well as record the EEG correlates of the sleep-related disorder. We'll look at a video in the next slide for that. And in absence of this, we would rely on screening questionnaires to try to detect and look at RBD. The evidence for treating RBD in context of PD is largely based on treating REM sleep disorder in other non-Parkinson's patients, and their clonazepam and melatonin have been tried. And it's very difficult to say that they will be effective in Parkinson's disease. The issue with benzodiazepines, whether used in the context of RBD or anxiety, is you have to carefully look at the level of motor impairment and then a possibility of falls and injury. So that has to be carefully assessed, as well as cognitive impairment. This is a video which will try to, if it plays, I'm not sure. Yeah, the patient is undergoing a polysomnography, and what you see is during the REM sleep, there is not all the muscles he is able to move, and he is in the dream arguing and fighting with somebody during the REM sleep phase. So this is one way of probably establishing the diagnosis. Other condition, suicide in patients with Parkinson's disease. The risk factors which possibly are implicated are depression and impulsivity. And PD patients with history of depression, psychosis, family psychiatric history, greater impulsivity and depression are prone to suicide. And higher rates have been reported among studies following DBS surgery. Although it is very difficult to clearly say what happens following DBS surgery, which results in this, but studies have looked at this aspect, and the suicide rates are higher there. Careful assessment of underlying depression, impulsivity, as well as other risk factors is important, and we need to treat them promptly and not let the disease progress to prevent suicides. Now, I'll be concluding the presentation. There is a higher cumulative prevalence of most neuropsychiatric signs and symptoms in Parkinson's disease, which has been reported in Western, as well as the recent study in India by Desai et al., which is reported that it is higher. And it is also important to understand that neuropsychiatric symptoms results in excess disability, worse quality of life, a range of poor clinical outcomes, and caregiver burden. Etiology is probably a complex interaction of the biological vulnerability with the psychosocial environment. And we need to systematically screen all PD patients at the onset itself as they are diagnosed in settings in geriatric medicine, or say in neurology, or in a general practitioner setting, and also consider possible future PD among psychiatric presentations which present in, say, middle life around 35-40 years of age, presenting with anxiety, depression, and be cautious about they having a chance of developing PD, although not very, it might be remote, but still we need to be cautious about that. And assessments for screening and severity are complicated by overlapping symptoms, both in clinical and research settings. And a role for novel drug targets is being explored for different drugs like pimavanserin, safinamide, and probably even the endocannabinoid system. And optimal management is limited by few established treatment options. And non-pharmacological management is very important, especially exercise and CBT. These are certain important things. And multidisciplinary management is the key. Multidisciplinary management, when we look at it, is probably best shown in this article in Lancet, which says that a person with Parkinson's disease is here shown as a son, and he is the center of it. And most of the patients, all the patients with Parkinson's are in touch with either a medical specialist or a general practitioner. This medical specialist can be a neurologist or a geriatric medicine specialist. Now, somewhere here also comes role for a psychiatrist, psychologist, social worker, speech therapist, occupational therapist, wherein most patients will need some or the other intervention from this add-on second layer of team. And finally, a specialist evaluation may be needed in different cases, depending on what presentation or what complication is adding on to the Parkinson's disease. So with this, I'll conclude the seminar. Any questions? At this point, probably I'll open the chat window as well.
Yes, sir. So some questions are there in the chat.
Yeah. I will just start addressing them. Okay. To manage the first question by Tanu Singla: how to manage psychiatric side effects of dopaminergic agents used to treat Parkinson-like psychosis. Okay. By this, I understand how much dose of anti-Parkinson drugs to be decreased. Okay. Now, again, this question where you're trying to say that possibly you are trying to say that dopaminergic agents and how they are in one way or the other affecting the psychotic symptoms like visual hallucinations, and how much dose of. So first you will need to, in the approach to psychosis involves ruling out other important conditions like delirium. So that is very important, that you will need to first rule out an important medical condition like delirium. Now, if you have moved forward from that, you need to assess what is the relationship of the psychotic phenomena to the on and off state. And if these are occurring, you will need to discuss with the neurologist as to how to proceed. Right. So how to proceed with the dopamine agonist therapy? What is the duration of dopamine agonist therapy? Is there a possibility of optimizing or changing the doses of these medications? So if that seems to work and help, then possibly you are in a better position. If that does not seem to work out well, then the other option would be to add on an antipsychotic if the symptoms are causing substantial impairment and dysfunction. Among antipsychotics, again, like clozapine and quetiapine are preferred, and many practitioners, individual practitioners, would prefer clozapine over the quetiapine. But again, many will prefer quetiapine because of need for less intense monitoring. Next question is, does treatment of PD improve neuropsychiatric symptoms independent of improvement in motor symptoms? Now, difficult to say. There are quite a few neuropsychiatric symptoms which emerge as a part of on and off phenomena. So you may find patients drastically vary during the on state and off state as the Parkinson's disease agonist therapy, especially in terms of the dopamine agonist, progresses after 5 to 6 years. You may find that there are drastic changes. So it is also recommended that any assessment of neuropsychiatric symptoms should be done twice. One is during the on state, also during the off state. Patients during the off state may have profound depression, anxiety, slowing, and which may totally go away, and patient may feel quite energetic and may feel also quite upbeat. Their mood might go up during the on state within a few hours of taking levodopa. So treatment of PD improves NPS. Treatment of PD, again, you are going to probably refer to dopamine agonist therapy. The dopamine agonist therapy, when we look at individual disorders like depression, anxiety, you have not seen conclusively that it is able to make a large impact on the overall improvement in those established disorders. If they're occurring as part of on-off state, optimizing dopaminergic therapy for Parkinson's might be an option. Or the other question from Tanu is, which dopaminergic agent to be preferred as an add-on therapy to Syndopa for treating keeping in psychiatry? Again, what has been used for some of the symptoms is selegiline, but again, selegiline will also predispose them to some other psychiatric side effects. So selegiline is one agent. Now, you're also looking at your other question is, which SSRI to be preferred for depressive and anxiety symptoms? See, there is, for depressive symptoms, yes, SSRI have evidence. What have been tried? Citalopram has been tried, as far as I remember, and then there are trials with sertraline, and I'm not able to recall. There are more SSRIs which have been tried, but for anxiety symptoms, SSRIs per se have been found effective. It's very hard to say. One is subjectively, there has not been much of a report that just with SSRI they have been able to find a substantial improvement. So may not be possible, but yes, clinically, often when they are referred to a psychiatrist, our first choice has been an SSRI. We would want an SSRI with, one is fewer interactions as well as fewer chances of sedation and lesser propensity of any kind of effect on the motor symptoms. So these are what we'll be looking at. Citalopram has been studied extensively. The other option has been escitalopram in clinical settings, which has been there. Now there comes another questions, how to identify PD-MCI. this is a challenging task because many of the screening tools for cognitive impairment are probably not some of the best for looking at cognitive impairment, especially when we look at tools like MMSE. MMSE probably is more suited for Alzheimer's dementia than for Parkinson's disease cognitive impairment. And here, one study has looked at use of MoCA. MoCA is possibly a better tool for screening, but many other cognitive instruments have been tried. And again, very tough to say ki you'll be able to easily identify. But the Movement Disorder Society recommends, I've again missed that. I'll be able to check that and get back to you, Pranjal, on what does the Movement Disorder Society recommend for screening for PD-NCI. The next question from again Pranjal is bupropion is a good choice in PD for anxiety or depression? What has been, I'll go back to my slides. Somewhere I did mention about bupropion. One minute, possibly. See, again, bupropion in the context of depression, I'm not very sure, but in the context of anxiety, yes. That's what I find that Visperon has been there. Somewhere bupropion I did come across in my reading that it is possibly more efficacious, but again I've not incorporated them in my slide. Apathy, yeah, sorry, in the context of apathy, but I've not found any literature looking at bupropion in the context of depression, anxiety. But in the context of apathy, yes, one trial is possibly there for bupropion. So again, further questions, if any, I saw. Okay, welcome, Pranjal. Any more questions?
Any more questions to Dr. Vikram? I would request comments from the senior faculty members, Chandra Madam, Vengamma Madam, KP Sir, Professor Satyaprabha, Professor Tali Sir, all of them to give your valuable comments and suggestions.
The funding, na?
Yes, ma'am.
How to manage? That's very difficult, na? Sometimes.
Funding is definitely, ma'am. Funding, when we look at it, funding is an interesting neuropsychiatric syndrome which has been described in this context. And it was initially reported in when people were studying amphetamine psychosis. So amphetamine psychosis is one condition in which specifically funding has been reported. And it is defined as a complex, non-goal oriented, stereotyped repetitive behavior. And it is one problematic compulsive behavior which occurs in the context of Parkinson's disease, especially as the treatment with dopamine agonist therapy goes on. And these behaviors can involve a wide range of presentations, which can involve simple things which are probably involved part of a person's job or profession, which have been repeatedly learned, or they can be new add-on phenomena. And also some strange complex behaviors are noted, like there are case reports of patients endlessly singing while on dopamine agonist therapy, as well as patients endlessly shuffling and reshuffling and arranging newspapers for hours together while on dopamine agonist therapy. Likewise, women resorting to repeated arranging or dressing themselves up. Although what happens is all of these behaviors are considered non-goal directed because it seems that none of them are completed and none of them result in cleanliness or orderliness. So the funding results in overall some of the other kind of disorganization, ma'am. But literature on funding I have not seen overall in terms of how one could go about whether they should optimize the dose of dopamine agonist. Here the difficulty comes that in funding, again, selegiline is not a good option because selegiline has amphetamine-like metabolites, which will possibly worsen the funding. So it may not again be a very good option. And Here, again, in the context of funding, I'm not sure matlab, there are trials. We have looked at literature, but I've not found any systematic trials or systematic assessment of funding. There has been one recent write-up by author Barbosa, which is there in 2022, which is available for reading. But again, these are very small patients, few patients, 3, 4, 5, 6, like that patients, and not able to conclusively say that some medication, probably non-pharmacological intervention or some kind of distraction may be an option. If the patient has concurrent dementia or depression, we'll have to carefully assess and try to see if we can address that and try to get this down. And also, we are not able to fully understand the underlying the basis for funding, because how it emerges during this dopamine therapy, whether the ventral striatal system gets hijacked in some way due to chronic dopamine overstimulation, and is funding just a behavioral equivalent of dyskinesias, which come during the on-off phenomena on state. So is something which has been proposed by some of them. So how we can regulate this dopaminergic alteration? Maybe some possibly case reports might be there on clozapine, but I'm not sure. I'll have to further look up. I couldn't find enough on funding, but it's a definite difficult problem in the context of Parkinson.
Yes, some of the patients, they say they buy huge amount of food materials.
Yeah, ma'am.
And leave it in the house, and the family members don't know what to do with that. And this happens again and again.
Yes, ma'am. So can attempt some kind of behavioral intervention if there is a possibility to negotiate and patient is communicative and also not slow down excessively due to cognitive and or motor symptoms. So we can try to attempt all distract and try to see, but then again, numbers of patients who have studied with this are few. But yes, it's an extensive problem because the rates of funding go up with 5 years of dopamine agonist therapy. What has been reported in literature is untreated patients have around 2 to 3%, but treated patients after 5 years of therapy have around 13 to 14% incidence of funding and hobbyism. These kind of problems exist.
Anyway, thank you very much, ma. Thank you. That was a very nice, useful presentation. Thank you very much.
So I think if there are no other questions or comments, I think we had a very fantastic lecture on the psychiatric aspects of Parkinson's disease, which is actually quite important topic and also one of the important exam topics, especially for neuropsychiatry residents. So I would thank the additional professor from AIIMS, Vikram sir, for sparing his valuable time on Sunday afternoon to provide us with these insights.
Thank you.
Thank you very much, and I hand over to Dr. Guru for concluding remarks. Thank you.
First of all, I would like to thank Professor Vikram Singh taking his time to present on Parkinson's aspect, the psychiatric aspect of the Parkinson disease. The seminar is very informative, and we have enjoyed the recent updates, and also it made us like a lot of things are happening in the area of Parkinson's disease and neuropsychiatric aspects, and it's very useful for all the postgraduates from the psychiatry and neurology. And thank you, sir. Thank you so much. And also express my gratitude to my friend Dr. Thomas moderating the whole session, as well as I would like to thank all the senior faculty, Professor Chandra Madam, Professor Tali sir, Professor Satyaprabha Madam, and Professor Krishnapada sir, who are also part of this program and encouraging us. Thank you all. And thank you all the participants who joined in the Sunday for the very interesting topic.
Thank you. Thank you. Thank you, Thomas.